Perfect. All right. Double thumbs up from Dr. Doctor. Thank you so much. I appreciate everyone for being here for our EM Critical Care Clinical Forum Resident Research Webinar, part two. Thank you all for attending today's presentation. We're a little tight on time, so we're just going to go ahead and get through the introductions. We're going to have five great presenters today. Our first presenter is going to be Dr. Taylor Fee from Jackson Memorial Hospital. Her presentation objective is listed there. We will then have Dr. Valerie Hernandez from Jackson Memorial Hospital as well. Her presentation objective is listed for you there. Next, we'll hear from Dr. Meredith McAfee from Memorial Regional Hospital, followed by Mackenzie Macbeth, Jackson Memorial Hospital, and finally from Dr. Marielle Mitchell from Memorial Regional Hospital. And with that, I will pop off and we are going to roll right into the presentations. Take it away, Dr. Fee.
Hi, everyone. Can everyone hear me? Okay, great. Okay, so again, my name's Taylor, and I'm going to be talking about blood pressure management protocol for ICH in the emergency department. So as we know, spontaneous non-traumatic ICH is a life-threatening emergency that accounts for 10 to 15% of strokes globally, and early mortality is about 30 to 40% for these patients. So it's something that is pretty significant. And despite its severity, therapeutic interventions for ICH have remained limited, largely due to lack of high quality evidence that's available. So for the acute hypertensive response, we know that's something that's common in ICH and is something that we can actually modify and early on in ICH management. So largely based off landmark trials such as the INTERACT-2 and ATTACK-2 trials, these two trials led to big guideline updates with recommendations to reduce blood pressure to 130 to 150 for most patients presenting with ICH and elevated blood pressures. This has been demonstrated to help improve functional outcomes and is considered safe in these patients. However, one of the things that we are lacking in data that's out there is the appropriate antihypertensives that are the key agents that we want to administer to these patients. We don't really have great guidance on which agent is preferred over others. So what RED did is it took a random sample of 21 patients with ICH alerts, and it looked at 10 patients who were given labetalol 10 milligrams first versus 11 patients who were started on cardine drips. And what it found is that there was trends towards faster times with the patients that started on labetalol than cardine versus just cardine alone. So based on this small random sampling, our stroke council at our institution requested a blood pressure algorithm for our ICH alert patients to help coordinate care. You can go to the next slide. Okay, and so based off that recommendation, this is what our institutional blood pressure management protocol looks like. So generally, it does vary sometimes based on patient but for the most part, our goal is 130 to 150 within 1 hour of ICH alert. If you look on the right, you can see heart rate greater than 55, age less than 90, and systolic greater than 160. We start off with a labetalol 20 milligram IV push. If for whatever reason they fall into the heart rate of 50 to 55, age greater than 90, or 150 to 160 of systolic, we give a reduced dose of 10 milligrams of labetalol. And then if heart rate is less than 50, we do not administer and just start the cardine drip. Following labetalol pushes, we go ahead and get this patient started on cardine infusions. And then also in 10 minutes, we can consider giving an additional labetalol dose if blood pressure is still elevated. So background information, our primary objective was the adoption and impact of protocol implementation on the time to achieve systolic control from ICH alert activation in patients presenting with acute ICH. We looked at several different time frames. So how fast did we get the med to the patient? How fast was the med ordered? How quickly were we getting these heart rate or these blood pressures lowered to goal? And then we looked at frequency of systolic blood readings outside of target range during ED stay after we already achieved initial control. We looked at incidence of hematoma expansion, incidence of protocol deviations, and then different subgroups as well. One of the subgroups we looked at was labetalol plus cardine versus just nicardipine alone for first-line agents for systolic control, and then also the presence of an ED pharmacist. Safety outcomes, incidence of hypotension, and bradycardia as well. Inclusion, we included adult patients with ICH alerts confirmed by CT brain imaging. Exclusion, patients who arrived by EMS or outside facility that were given an antihypertensive medication IV. Initial systolic less than 150, patients with subdural, subarach, or traumatic ICHs, and then canceled or inpatient ICH alerts. So it was a single center observational chart review of patients at Jackson Memorial's ED. We retrospectively reviewed data from August 1st, 2024 to March 31st, 2025, and we included 42 patients out of 164 patients. Most common reasons for exclusion were either transfers, subdural, subarach, or traumatic ICHs, systolics less than 150, in-hospital ICH of 3, and canceled stroke alerts of 16 patients. So when it came to demographics, our median age was 62, 60% were male, 64% with history of hypertension, 14% with stroke or ICH. Prior to this event, 17 was the median NIHSS score, ICH score median was 1. Initial systolics was 196, followed by 115 for diastolic and a heart rate median of 88. Labetalol was administered first line as in 32 of our patients, so 76% versus 10 patients that were started on nicardipine only. As for primary and secondary outcomes, so our primary outcome, we found ICH alert activation to goal systolic blood pressure of 78 minutes median. ICH alert to first blood pressure medication administered 9 minutes, antihypertensive medication administered to goal BP of 58 minutes. We found that 17 patient or 40% had a blood pressure reading outside of their documented goal while they were staying in the ED. We did have one patient with bradycardic events and then 3 patients with episodes of hypotension. As for hematoma expansion on CT, 52% were improved or stable, 43 worsened, and then 7 were unknown, or 7%, excuse me. As for other data points, for ICH blood pressure management protocol followed, we had 48% that were incorrectly followed, most commonly due to nicardipine titrations being titrated too quickly, so titrated by increments of 5 instead of the 1 to 2.5 milligrams. And then also labetalol not administered first when indicated, or if they received 10 milligrams instead of the 20 milligrams based on their criteria. As for presence of an ED pharmacist, antihypertensive administered with an ED pharmacist on duty was 9 minutes versus 20 minutes without one. And then antihypertensive administered to goal with an ED pharmacist was 58 versus 55 without an ED pharmacist, so pretty equivalent. As for initial blood pressure agents being given to these patients, we saw that when we gave labetalol first, we found median times of 49 minutes to goal versus 134 minutes when nicardipine was started initially without labetalol. And when you look at this on a chart, you can see time from antihypertensive administered to goal. The light blue is labetalol, so you can see trends towards much faster times when labetalol was given, followed by cardine versus just cardine alone for these patients. So in conclusion, median time to systolic goal was 78 minutes. Again, we did see trends when given labetalol up front, followed by that cardine drip. We also found that ED pharmacists there did shorten time to the medication actually being administered to the patient. We didn't see this affect systolic goal. One of the main reasons that this is probably occurring is because our documentation, they document Q1 hour or with cardine titration. So it is hard to kind of get out when we actually do reach goal. It could be faster than what's documented. We just don't necessarily know. So that was one of the limitations of this study. Also, we had a relatively small sample size. Again, timing and documentation was a big limitation. And then this was a protocol that we followed. So this was kind of a post-protocol approach. Comparing it to data pre-protocol would be interesting to see the differences in times of a protocol implemented approach versus pre-protocol. And then just a real life example that 40% of the patients did not maintain blood pressure while in the ED. So very important once we get to goal to try and maintain goal while they're being housed in the ED. So overall, this does show the feasibility of having a blood pressure protocol for ICH alerts in patients in the ED. It does also demonstrate documentation gaps and variable blood pressure control as being things that we need to keep in mind. And prospective studies can be needed to kind of help us figure out what is the best agent for these patients as well. My references, and with that, I'm open to any questions.
All right, thank you so much. Does anyone have a question?
I do have a real quick question. Thank you for that presentation. Very good. Nicardipine, why would we do the 10 to 15 titration rate instead of the Q5?
So our protocol is a titration of 1 to 2.5 milligrams every 10 to 15 minutes, just because of when it peaks. A lot of the times we'll walk into scenarios where it's being titrated too fast. And when that happens, actually the patients with hypotensive, two of them were because of too fast of cardine titrations. They weren't allowing for the 10 minutes to occur between titration. So it did lead to hypotensive events versus um, we found that when we do that upfront labetalol and then start the cardine drip, it's generally pretty effective in these patients. I will say sometimes they do titrate a little bit faster, but per our protocol, the 10 to 15s is solely based on the kinetics of the drug.
Okay. So, usually I'll be real quick, just that, in emergencies in which, in this case, it would be deemed an emergency where time is a factor, titrating Q5 minutes until you hit goal and then reducing it to 3 milligrams an hour seems to really help prevent that hypotensive bounce back that you might experience. So just something to consider. It is written in the package insert that way too for emergency use. So just found that part interesting. Not a negative, just a comment. Thank you. Very good.
Yeah, thank you.
All right, thank you, Dr. Fee. We will move on to our next presentation, and that will be by Dr. Valerie Hernandez.
Hi everyone, can everyone hear me? Yes, no.
Yes.
Okay, thank you. Hi everyone, my name is Valerie Hernandez. I'm the PGY2 Critical Care Pharmacy resident at Jackson Memorial Hospital, and I'll be presenting my project on evaluation of prescribing practices for prophylactic antibiotics in operative and non-operative facial and skull fractures. The investigators have nothing to disclose. And the objective of this project was to evaluate prescribing practices of antimicrobials in patients with facial and skull fractures at Jackson Memorial Hospital. So for a bit of background, facial and skull fractures are frequently seen in traumatic injuries, whether resulting from a fall from standing height or a self-inflicted gunshot wound. Facial fractures often involve various injury patterns and can have different levels of contamination due to their close proximity to the oral cavity, sinuses, and nasal passages. For example, mandibular fractures are greatest risk of developing these infections because of the gingival sulcus, which favors contamination via the exposure to the oral environment. Unlike other open fractures, surgical repair is often delayed to address more life-threatening injuries or to allow the edema to decrease, which is why it's common practice in operative facial fractures to administer preoperative and postoperative antibiotics. While the effectiveness of pre and perioperative antibiotic prophylaxis is known, it remains uncertain whether a postoperative course of antibiotics reduces the risk of infection, and if it does, to what extent. Across the nation, there's a large variability in practice patterns among treating these fractures, and many providers continue prophylaxis longer than is needed, which you can see here in the screenshot of one of the notes in our hospital of OMFS recommending a total of 14 days of antibiotics for a facial fracture. However, the use of antibiotics is not without its problems, and it can be associated with adverse effects, drug interactions, and contributes to increasing bacterial resistance. And given this growing concern of antibiotic resistance, it's important to limit antimicrobial prophylaxis to the shortest amount of duration necessary. So when reviewing the existing literature comparing the efficacy of extended versus shortened durations of antibiotics in patients with mandibular fractures, these two randomized control trials evaluated the effectiveness of a 24-hour antibiotic regimen compared to an extended 5-day course. And each patient received IV augmentin for 24 hours, with the extended group continuing an oral antibiotic course for an additional 4 days. And both trials found that there was no significant difference in postoperative infection rates within a 6-month period between the short and extended treatment groups. And these results suggest that prolonging antibiotic therapy beyond these 24 hours postoperatively does not provide a meaningful advantage in preventing infections. When considering even shorter antibiotic courses, The Campos and colleagues conducted a randomized trial in patients with facial fractures, and one group received no post-operative antibiotics while the other received 24 hours of cefazolin. And infection rates were significantly lower in the 24-hour group, 3% compared to 14%, supporting the benefit of short duration prophylaxis. In contrast, though, the Zosa and colleagues performed a retrospective cohort study in ICU patients with facial fractures, and patients were grouped by antibiotic duration, so less than 24 hours versus greater than 24 hours with a median of around 7 days. And surprisingly, the longer duration group had higher infection rates. And when looking at the adverse effects associated with these extended use of antibiotics, Operator and colleagues conducted a systematic review across ENT and OMFS studies comparing prophylaxis for less than 24 hours versus greater than 72. And adverse events rose from 3% to 8% with a relative risk of 2.4 for these longer durations. And similarly, a retrospective study on non-operative facial fractures found 0% incidence of C. diff colitis in both no antibiotics and short-term groups, but 0.5% in the long-term groups. So due to these inconsistencies in antibiotic prescribing practices, the American Association for the Surgery of Trauma Critical Care Committee recently published a consensus document regarding antibiotic prophylaxis and injury. And in this document, they recommended no prophylactic antibiotics for closed, non-contaminative operative facial fractures, pneumocephalus, and CSF leaks. And they recommended prophylactic antibiotics for greater than 24 hours or less for open and contaminated facial fractures and scalp lacerations. And they recommended a short course of prophylactic antibiotics for less than 3 days for patients who have a penetrating brain injury. And the recommended antibiotics are on the slide. So why conduct a study? As I have been alluding to in my presentation, there have been evidence for increasing rates of resistance with unnecessary prolonged antibiotics. And we know that the extended use of antibiotics increases the disruption of the patient's normal flora, increasing their risk for other infections. And duration of therapy remains controversial as most published studies are inherently biased and underpowered. And currently at our institution, we don't have a standardized treatment algorithm for these type of open fractures. So we conducted a single center retrospective chart review between July 1st of 2023 to July 31st of 2024. The study included adult patients greater than 18 years or older with facial and depressed skull fractures, and excluded any patients with an acute bacterial infection requiring treatment with antibiotics or a history of malignancy or radiation. This graphic just shows some of the data collection points that we looked at. And as for the population in our study, we initially screened 122 patients for inclusion of the study, and a total of 22 patients were excluded based on our predefined criteria. So 10 had an acute bacterial infection requiring antibiotic treatment, 1 had a history of malignancy or radiation, 7 had no fracture that was confirmed, and 4 patients, unfortunately, had expired due to their injuries. So this left us with a final study population of around 100 patients. Next. Yeah. Our primary outcome was the appropriateness of antibiotic prophylaxis determined by the adherence to the AAST recommendations. And we also looked at the duration of antibiotic prophylaxis, including the duration of antibiotics recommended by the consult service and the duration deemed appropriate by the primary team. And these were some of the secondary outcomes that we looked at, including type of antibiotic prescribed, any adverse effects, including C. diff or AKI, rates of antimicrobial resistance, reoperation rates, and then any discharge antibiotics if they were sent home on. Click again. Yeah. Among the 100 patients included, the median age was around 39 years old, with 77% of them being male, and a median weight of around 73 kilograms. Racial distribution was 56% white, 40% Black, and then 4% other. The most common fractures were zygomatic, skull, and mandible of around like 28, 27, and 26% respectively, with fewer cases of orbital, left fore, nasal, maxillary, and penetrating brain injuries. And then 70% of patients underwent surgical intervention, and the most common consulting service was OMFS, followed by neurosurgery. So our primary outcome, oh, yeah. Our primary outcome was adherence to the AAST antibiotic recommendations, and as shown here, only 27% of cases adhered to the guidelines, while 73% did not. However, it's important to note that our institution does not currently have formal guidelines in place for antibiotic use in these cases. However, we use the AAST recommendations as a standard benchmark to evaluate our current practice. While we found that only 27% of patients adhere to the AAST recommendations, we wanted to look more closely at the actual antibiotic durations compared to those recommended in the guidelines. So the median recommended duration was found to be by the consulting service was 5 days, with an interquartile range of 2 to 8 days. However, in practice, patients received a median of 3 inpatient days of antibiotics, ranging from 1 to 5 days. And then when combining both inpatient and outpatient antibiotics, the total duration increased to a median of 7 days, though the interquartile range was 0 to 5 days, suggesting a wide variation on how the antibiotics were prescribed and who got antibiotics outpatient. As for our secondary outcomes, the most common antibiotic used was Unison, with around 50% of patients receiving Unison. And as for our secondary outcomes, acute kidney injury occurred in 15% of patients and 48% were discharged with antibiotics. We also found no cases of C. diff infection and low rates of reoperation and antimicrobial resistance, both at 2%. So overall, this review demonstrated discordance in treatment practice in comparison to the guideline recommendations for facial and skull fractures. Only 27% of patients adhered to the AAST recommendations to discontinue antibiotics within 24 hours, whereas 73% received antibiotics beyond this duration. Patients were given antibiotics for a median of 7 days when including outpatient prescriptions, and nearly half of the patients were discharged with an ongoing antibiotic prescription. Unison was the most frequently prescribed antibiotic, comprising approximately 58% of all courses, and antimicrobial resistance developed in 2% of patients following prophylaxis. And although no cases of C. diff infections were observed, 15% of patients developed acute kidney injury. There were several limitations to our study. So first, it was a single center study, which may limit generalizability. And it was also a retrospective chart review. So we were relying on the existing documentation, which was sometimes inconsistent. And the sample size was relatively small, only including 100 patients, further limiting the statistical power. And lastly, our assessment of the antimicrobial resistance was restricted to the data at our hospital. So lastly, for our action plan to address the variability in antibiotic use, we proposed a two-part intervention. So first, under protocol implementation, we aim to create a standardized antibiotic prescribing orders for facial and skull fractures, clearly defining agents, dosing, and duration. And this would be developed in collaboration with the trauma team and presented to the consulting services. And then second, under education and awareness, we plan to conduct a provider education session to highlight the new protocol, and then update our Cerner order sentences and power plans to reflect the changes. And that is all I have. If anyone has any questions.
Hello, good job. This is Angel Maldonado. I just have one question, if you can hear me.
Yes, I can hear you.
I was wondering, very nice job with the presentation, but I was wondering if you had a maintenance protocol for this population, and also if you noted the number of patients that had to have their jaw locked with. Sometimes they just lock the jaws because of the fractures in order to maintain the fractures from moving.
Yes. So we currently don't have a protocol in our institution that guides like the maintenance antibiotics that they receive.
Oh
Um,
no, I'm sorry. I mean maintenance as far as like regular maintenance, like the use of antibacterial mouthwashes or topical solutions, like what's called hexa.
Yeah, the chlorhexidine.
Yes, chlorhexidine.
So again, we don't have any like set protocols for that, but I did notice that the patients, like the consulting service were also recommending those, but we didn't look at that in our I didn't data collect on that,
Okay.
whether the patients like all received that or there was inconsistencies between patients.
Yeah, just because topical reducing the burden of the microbes would help minimize
The use of
translocation. Yeah.
Yeah.
Okay, thank you.
No, thank you.
All right. Thank you very much, Dr. Hernandez, for your presentation. We will move along with Dr. McAfee. Take it away.
Can everyone hear me okay?
Yes.
Okay. So hi everyone, my name is Meredith McAfee and I'm the PGY2 critical care resident at Memorial Regional Hospital, and I'll be presenting my research on multimodal analgesia in adult trauma critical care patients. I have nothing to disclose, and these are the abbreviations I'll be using throughout my slides. And at the end of the presentation, the audience should be able to evaluate the impact of multimodal analgesia on morphine milligram equivalents or MME requirements in trauma ICU patients. And then before we dive into the study, I want to briefly highlight where it was conducted. So Memorial Regional Hospital, it's a 797-bed community hospital located in Hollywood, Florida, and serves as a level 1 trauma center. So a survey found that 75% of individuals with opioid use disorder started with a prescribed opioid, which highlights the need for alternative strategies. So as a result, many hospitals have adopted multimodal analgesia, which is the use of more than one pharmacologic class of analgesic medications with different mechanisms of action, with the goal of managing pain and minimizing opioid exposure. You can go to the next slide. So this table highlights several key retrospective studies that evaluated multimodal analgesia in trauma patients. I'll only discuss a few. So starting with Euler et al. Was in 2018, and this study included trauma patients over 18 and excluded patients with abdominal surgery, head injuries, or illicit drug use. But they found that patients who received multimodal analgesia had significantly lower discharge morphine milligram equivalents. So that was 45 milligrams versus 90 milligrams in patients that had no multimodal. And then Sparks Joplin et al. Was in 2022, and this found an overall MME per day reduction from 109.6 to 70, which was a 36.1% decrease. And the greatest benefit was seen in patients with an injury severity score greater than 16, where there was a 52.1% decrease. So overall, these studies consistently show that multimodal analgesia can reduce opioid exposure. You can go to the next slide. So based on the growing evidence, Memorial Regional Hospital had implemented our own multimodal analgesia pain protocol in the trauma ICU. And this protocol included non-opioid agents such as scheduled acetaminophen, NSAIDs, and gabapentinoids, as well as adjuncts like muscle relaxants, topical anesthetics, and opioids only as needed. And the purpose of our study was to formally evaluate how this protocol impacted MME requirements in trauma ICU patients. Go to the next slide. So this was an IRB-exempt single-center retrospective chart review, and the study spanned a full calendar year from January 1st to December 31st, 2024. And for the statistical analysis, we used descriptive statistics to summarize baseline characteristics and outcomes. And the Kruskal-Wallis test was used to assess differences in MMEs per day, and a post hoc comparisons were performed using Dunn's test with Bonferroni correction. You can go ahead to the next slide. So to be included, patients had to be admitted to the trauma ICU between January 1st and December 31st of 2024, be at least 18 years of age, and have received a multimodal analgesia regimen during their ICU stay. And we excluded patients with known allergies to opioid medications, those with active pregnancies, and anyone on home methadone or buprenorphine therapy, as these factors could significantly confound opioid requirements. And additional exclusions included patients who died within 24 hours of multimodal analgesia order, those with hospital length of stay under 72 hours due to limited exposure time, and any patient transitioned to comfort measures during their admission, as this would alter analgesia goals. You can go to the next slide. So for this study, we defined multimodal analgesia as the use of 2 or more pharmacologic classes of analgesic medications in addition to an opioid. Our primary outcome was the daily change in MME requirements in adult trauma ICU patients, and we also evaluated several secondary outcomes which included ICU and hospital length of stay, the use of naloxone, an opioid reversal agent, as a surrogate for opioid-related adverse events. We also looked at ileus incidence. And additionally, we recorded whether patients were discharged with an opioid prescription, and we identified the most frequently used non-opioid analgesic agents at Memorial Regional Hospital to better understand prescribing patterns. You can go to the next slide. This slide summarizes the baseline characteristics of our study population, which included 42 patients. The median age was 34.5 years. We had a wide range from 18 to 86 years, indicating a diverse adult population in terms of age. The majority of patients were male, accounting for over 70%, which is not unexpected in a trauma population. When looking at comorbidities, most patients had relatively few chronic conditions. Substance abuse history was present in about 21% of the cohort, with alcohol being the most common at 12%, and only 2 patients had documented opioid use. And these demographics are reflective of the typical trauma ICU population at our institution. You can go to the next slide. This pie chart looks okay. This pie chart shows a distribution of trauma mechanisms among the 42 patients included in our study, the most common being motor vehicle collisions, which was 33% of cases, which is consistent with national trauma trends. Falls were the second most frequent at 17. Gunshot wounds made up 14% of the cohort, which highlights the presence of penetrating trauma in our population. And pedestrian struck by vehicles was 12%, and motorcycle collisions made up 19%. And then the variety of mechanism reflects the diverse and high acuity trauma population seen at our center. You can go to the next slide. This slide provides a clinical snapshot of the patients during their ICU admission. So starting on the left, 66.7% of the patients were intubated, which aligns with the high severity of injuries in our trauma ICU. And among those patients, 62% required a fentanyl infusion. Fractures were also extremely common in 93% of the patients, with rope fractures being present in 43%. And on the right side, we have the procedural burden for our patients. So over a third of patients underwent one procedure, 21% had none, and 9.5% had 4 or more procedures during their ICU stay. You can go to the next slide. And we'll just move on to the results. You can go to the next slide. So this box plot illustrates the primary outcome of our study, the daily change in MMEs over the first 5 days of multimodal analgesia. So on day 1, the MME requirements were the highest, with a wide distribution and several outliers above 300 to 600 MMEs, reflecting patients with high analgesic needs immediately following their trauma and surgical interventions. And then as you move from days 2 to 5, there's a clear progressive downward trend in both the median and interquartile range of the MME used. This suggests that a multimodal analgesia was continued, opioid requirements decreased steadily. You can go to the next slide. To summarize the findings from our primary outcome, we observed that 66.7% of the patients, or 28 of the 42, had a reduction in MMEs by day 5 of ICU admission. The average % decrease in opioid requirements across this group was nearly 68%, which is both clinically and statistically significant. And then to further evaluate where the most meaningful reductions occurred, this is where we used Dunn's test with Bonferroni correction. So comparing day 1 to day 3, we saw a statistically significant reduction. This is also seen from day 1 to day 4 and day 1 to day 5. So this result indicates that our multimodal analgesia protocol had a rapid and measurable impact in reducing opioid exposure. You can go to the next slide. So this table breaks down the non-opioid analgesics most frequently used. So acetaminophen was universally used, so in all 42 patients, with the majority receiving it on a scheduled basis. We also had gabapentin being used in 93% of patients. NSAIDs were used in 31% of cases, with PRN dosing being slightly more common than scheduled. Lidocaine patches were employed in 40% of the patients, often for localized pain for our rib fracture patients. And then methocarbamol was used in over 90% of the patients, almost entirely scheduled instead of as needed. And tramadol was rarely used, appearing in only 2 patients, and only on an as-needed basis. So overall, acetaminophen, gabapentin, and methocarbamol form the foundation of therapy at Memorial Regional Hospital. You can go to the next slide. So this bar graph just highlights the number of additional non-opioid analgesics used per patient. So the majority of patients received either 3 or 4 non-opioid agents, with 18 patients receiving 3 and 17 patients receiving 4. And then a smaller number, so 5 patients received 5 agents. You can go to the next slide. So this slide represents both the length of stay and adverse reaction outcomes in our trauma ICU patients. So the average total hospital stay was around 17.9 days, and then of that, 9.3 days were spent in the ICU. No patients were given naloxone, and ileus occurred in 4 patients. That's a known complication of trauma and opioid use, and it was present, but the incidence remained relatively low. You can go to the next slide. And this pie chart shows the proportion of patients who were discharged with an opioid prescription. So despite the consistent use of multimodal analgesia, 71% of our patients were still discharged with an opioid. That said, 29% of the patients were discharged without any opioid, which is a meaningful improvement compared to historical norms in trauma populations. And it also suggests that a third of our patients, their pain was effectively managed without requiring continued opioid therapy. You can go to the next slide. So I just wanted to talk about the limitations. So first, this was a retrospective single center study, which limits the generalizability. This was a single group study as well. So we didn't have a formal comparator arm. Our sample size was relatively small with just 42 patients. There were also several potential confounders that we couldn't fully control for, which was injury severity, intubation status, number of procedures performed, patient's baseline opioid status, and then individual prescriber prescribing patterns. And then we had a lack of standardized pain assessment documentation, specifically CPOT scores in our intubated patients. So this limited our ability to correlate opioid use directly with patient-reported pain control. You can go to the next slide. So to summarize, we observed a statistically significant reduction in MME requirements from days 1 to day 5 of multimodal analgesia. And that is it. You can go to the next slide. And these are just some acknowledgements that I have. And then you can go to the next slide, and those are my references. Does anyone have any questions?
All right, so we have one quick question for Dr. McAfee. All right, hearing none, we will thank you very much for your presentation, and we will move on to Dr. Macbeth. Go ahead.
Hi, my name is Mackenzie. I am one of the PGY2 in emergency medicine at Jackson Memorial Hospital. And today I'm presenting on the assessment of first-line therapies for acute agitation in the ED. Neither I nor any of my preceptors have anything to disclose. So the objective of this presentation is just to discuss the implementation, adherence, and outcomes of an institutional pathway that was implemented for first-line agents for agitation within the emergency department. A little bit of background, of course, we all know agitation is a common problem that's encountered daily within our emergency departments. And within March 2023, our ED pharmacist actually created an evidence-based agitation pathway that incorporated the use of droperidol, olanzapine, midazolam, and ketamine as first-line agents for pharmacologic agitation management. And so, we have previous literature ranging from 2017 to 2022 looking at, retrospective as well as prospective literature, finding that, next slide. When you look at literature as well as with our 2023 guidelines, we have this recommendation for rapid efficacious treatment with a combination of droperidol and midazolam, and it's backed up by literature, finding that droperidol and midazolam compared to other agents, that combination therapy reduces time to adequate sedation as well as reduces rescue sedation that's needed with other agents. Next slide. This is an example of our pathway that was instituted at our hospital, where we provided education to our providers, and a large portion of our education, of course, goes to our residents here at Jackson, as well as our attending. So if you briefly to follow it, of course, agitation is a little bit difficult to classify as mild, moderate, severe in the ED, but we do give suggestions for IV, intramuscular, as well as PO agents, single use or combination therapy. So this is what we're evaluating to see if they were following this. Next slide. This is a single center retrospective chart review that we conducted here at Jackson Memorial. We looked at patients on the 1st, 5th, 10th, 20th, and 30th day of months from March to August. So it totaled to about 35 days of data. We gathered patients based off of the omnicell pools of parental droperidol, Haldol, ketamine, lorazepam, midazolam, and olanzapine. And when we looked at including and excluding patients, of course, we included all these omnicell pools. And then based on chart review, we looked at patients and included them if they were given these meds for agitation, if they were harmful to self, harmful to others, if they were Baker-acted, or if they have any sort of note of disturbing the environment. We did exclude patients that these agents were used for alcohol withdrawal, anxiety, if they were corrections or prisoners, if it was just not used for agitation, some other documented reason, if it was not ordered by an ED provider, if the patient was pregnant, or if they were having seizures. Next slide. Our primary outcome was looking at the percentage of patients that received first-line therapy based on that pathway, and we defined that initial use of either droperidol IV-IM, olanzapine IV-IM, midazolam IV or IM, only IV lorazepam, and then ketamine IV or IM, or any combination that was on our pathway. When we look at our results, we do see that when we're looking at, we have screened 442 patients, and we ended up including 158 patients, and we excluded 284. When we look at our baseline characteristics of our patients, we can see an average age of 41 years, and almost 63% were male. When we look at our reasons for agitation, we can see that a majority of our patients were agitated either due to psych issues or alcohol intoxication, as well as when we look at patients that had a psych history, we see our most common history being schizophrenia, as well as bipolar or suicidal ideation, but still a large percentage, almost 38.6%, still had no psych history. And so we also looked at documented toxicity, so whether there was a stimulant, depressant, alcohol, any other sort of illicit drugs that were documented, if it was a documented toxicity of psych medications, or if there's no documented history of toxicity. Next slide. When we look at our primary outcome, we did see that 61.4% or 97 patients did have some sort of initial therapy from that pathway. So on the right side, you can see where we look at first-line combination therapy. The little asterisk does mean it was on the JHS pathway. So we can see the combination of droperidol with midazolam, 36 patients received that combo therapy. And then we move down to monotherapy, we can see our marked first-line agents that are on the pathway compared to our non-pathway agents. And so we can see that overall there was a large spread of use of what agents are being used for agitation within our ED. Next slide. So we wanted to look at the effectiveness of what we're utilizing. So this here is a graph of our single-use or monotherapy agents, as well as the other category is any sort of random combination. And so whether these patients received rescue sedation within 1 hour, within 1 to 2, like from hour 1 to hour 2, or if they received rescue between hour 2 and hour 4. So we can see that we are looking, when we look at our like midazolam and our lorazepam, we do see a larger percentage of patients that are requiring rescue therapy within all 3 categories. So within 1 hour, 2, and 4, comparatively to our droperidol or Haldol monotherapy. When we look at our combination effectiveness status, we really wanted to kind of lay out a droperidol midazolam compared to like a Haldol or haloperidol lorazepam plus or minus Benadryl or diphenhydramine. We do see a larger use of these combination meds compared to our monotherapies. And so we can see that surprisingly, our combination of haloperidol lorazepam diphenhydramine had less rescue within 1 hour, as well as within hour 1 and 2. But we do see reduced rescue sedation needed during hour 2 of 4 for our droperidol midazolam. And so we kind of found that this was interesting. Next slide. Of course, we wanted to evaluate our safety data. So we looked at patients and whether their oxygen saturation was documented as being below 90%, which we only had 2 patients or 1.3%. We did have a larger percentage of patients, I should say, that did require supplemental O2, 12%. And this was documented, it was counted if it was prior to the meds as well as after the meds. And then we did actually have 1 patient that required intubation for oversedation. And then we wanted to evaluate the use of EKGs and looking at QTCs in relation to these antipsychotics or meds that may prolong our QTC. So we can see about 26% did have an EKG prior to medication administration, and 48.7% received an EKG after the medication administration. And only 2 patients, or 2.3% of our group, actually had an EKG prior to and after medication administration. When we look at vitals, we can see we looked at our systolics, diastolics, as well as heart rate and our O2. So if you see the systolic blood pressure change, we did have a median change of -5, so a decrease of 5 after medication. We had a decrease of 4.5 in our diastolic, and we had a decrease of 6 in our heart rate change after our medications. And we really didn't see any median change of our oxygen saturations after our medications. Next slide. After, conducting this research project, we kind of reevaluated and see how we can take it and come back and improve our practices. So we wanted to look at our prescribing data. So we really wanted to compare our resident versus attending prescribing patterns, as well as our day shift versus night shift. So we define that as like 7 a.m. to 7 p.m. And so we saw that when we look at single use or monotherapy, it's pretty split on our droperidol monotherapy of resident versus attending day and night, similar with haloperidol and midazolam, but we do see a larger increase in attending use of our lorazepam monotherapy. And then when we look at our combination therapy, the main difference that I see is our droperidol midazolam compared to our haloperidol, lorazepam, and diphenhydramine. Where with our droperidol midazolam, we do see an increase in resident use and a decrease in attending use. And it is opposite for our haldol, lorazepam, diphenhydramine, where we see 22 of those 25 doses were prescribed by attendings, even day and night, but definitely more use for our attendings compared to our residents. Similar to our other agents, which if you refer back to an earlier slide where I had listed out all the different combinations of use of medications, those all were kind of, if they didn't fit into like a monotherapy, a clear monotherapy, they were grouped into this other. And so we do see the attendings, 14 of the 19 that are in this other group are some sort of weird combination that was prescribed by an attending. Next slide. So when we, look in conclusion and what we take away from this research project, we're glad to see that our residents demonstrated a strong adherence to their pathway. Their prescribing practices largely aligned with that pathway. And so we feel confident in our education that we have been giving them, and it's helped to reinforce that. So we will continue to educate, of course, all our new classes and continue to use this pathway. We did see that opportunity to strengthen our attending prescribing practices and maybe even provide some education to them as well with the pathway. I'm not sure, whether they know it's there or not, or just, it just needs to be some more conversation about it. But it was really good to see that of all these things, we do have safe practice. And so our recommended practices are safe. And so we are going to continue to educate on our practices for agitation in the emergency department. Next slide. I think that's all. Thank you. Any questions?
Any questions for Dr. Macbeth? We got Ruben saying great job. Thank you very much.
Thank you.
All right, hearing no questions, we will move on to our last presenter, Dr. Mitchell.
Good afternoon, everyone. My name is Mireille Mitchell, and I'm a PGY2 emergency medicine pharmacy resident at Memorial Regional Hospital. Today, I'll be sharing my research on the impact of bridge therapy on sedation and analgesia requirements in intubated patients in the emergency department. Rapid sequence intubation is the preferred method of emergent airway management, and it encompasses a short active sedative followed by a neuromuscular blocking agent. There is a risk for awareness with paralysis with rapid sequence intubations if sedatives or analgesics are not promptly initiated. Despite the frequency of RSI in the emergency department, post-intubation sedation practices are highly variable. There has been reported sedative delays of up to 50 minutes in patients, and even about 10 to 25% of ED patients have received an additional neuromuscular blocking agent without a corresponding increase in sedation. So therefore, this highlights a critical need for structured sedation strategies immediately following intubation, what we're terming bridge therapy. The primary objective of our study is to evaluate the incidence of patients requiring at least one rescue bolus and/or increase in rate of continuous infusion within 2 hours of intubation. And a rescue bolus will be defined as a subsequent administration of analgesia or sedation due to uncontrolled pain and/or agitation following the initial bridge or loading dose and continuous sedative. For secondary objectives, we're looking at time to first rescue bolus, total number of rescue boluses administered over 12 hours, total cumulative dosing, rate of extubation within 48 hours, total ICU stay, hypotension, and agitation, which we are defining as sustained tachycardia with a heart rate greater than 100 beats per minute and a systolic blood rate greater than 150 milligrams of mercury sustained longer than 5 minutes. And so the hypothesis for this study was that patients who receive bridge therapy are less likely to require rescue sedation or analgesia boluses. This study was a retrospective cohort study that took place between July 2023 to July 2024. We looked at adult intubated patients that were mechanically ventilated in the emergency department, then subsequently admitted to an intensive care unit. And for our research, again, bridge therapy was defined as a patient that received IV push boluses of sedatives and/or analgesics within 15 minutes immediately after intubation prior to continuous sedation initiation. And our data source was Epic EHRs. Our inclusion criteria was adult patients that were intubated in the emergency department that were mechanically ventilated via endotracheal tube and administered a neuromuscular blocking agent. We excluded patients that were intubated for less than a day, death prior to discontinuation of mechanical ventilation, received light sedation prior to intubation, and patients whose sedation was strictly managed with boluses and were not initiated on a continuous infusion. We evaluated 375 patient charts, and 146 patients were excluded due to death prior to intubation, intubation less than a day, incomplete documentation, and 2 patients being transferred out. In total, we had 229 patients included in the study, with 63 receiving the bridge therapy and 165 patients not. Looking at our baseline characteristics, the average age was about 60 years old. Most of the patients were of male sex, about 50.8%. There was no significant differences in ethnicity. The average blood pressure was about 147 systolic and 91 diastolic. The average lactate was 1.6 millimoles per liter, and the creatinine was similar across groups. There was no statistical significance observed in baseline characteristics between groups. Etomidate was the most frequently used agent for induction overall, with 89.5% of patients. In bridge therapy, that was about 84.1% versus no bridge, 91.5%, not statistically significant. That was then followed by Versed, ketamine, morphine, then propofol. And for paralytic agents, the majority of patients did receive succinylcholine in the bridge therapy group versus the no bridge therapy group. The majority of those patients received rocuronium. Among patients who received bridge therapy, the medications utilized were Versed, followed by fentanyl, ketamine, and propofol. And these patients were administered in bolus form immediately after intubation and prior to the initiation of a maintenance sedation in accordance with our definition of what bridge therapy was. Our primary outcome evaluated whether patients needed rescue sedation within 2 hours. About a third of our patients in each group required it, 33.3% with bridge, 36.4% without. The difference was not statistically significant, though the odds ratio numerically did favor bridge therapy, leading to a possible conclusion that there may be a trend towards a reduced rescue need, but it was underpowered to detect modest effects. Bridge therapy did significantly delay the need for rescue sedation, suggesting better early sedation coverage, and that p-value was significant. Bridge therapy also did result in a higher cumulative doses in the bridge group, likely reflecting a proactive sedation, not necessarily over sedation, as agitation rates remain similar between the two groups, which we'll go and talk about in the next slide with safety outcomes. Patients who received bridge therapy were significantly more likely to be extubated early, which was a potential meaningful ventilator outcome, and that p-value was significant as well. However, hospital length of stay was longer in the bridge therapy group, and that was significant as well. Looking at the safety outcomes, there was no statistically significant difference in rate of hypotension between groups. There was a slightly higher percentage of vasopressor use in the bridge group, but not statistically significant, suggesting there was no increase in vasopressor requirements. Despite the bridge group receiving more sedation, rates of agitation did remain similar. And so overall, the key takeaway was that bridge therapy was not associated with increased rates of hypotension, vasopressor use, or agitation, suggesting that early sedation did not compromise hemodynamic safety. In summary, bridge therapy didn't reduce rescue sedation rates outright, but it did delay them, with a delayed time to rescue sedation, a higher cumulative sedative dosing, and an increased rate of early extubation. And these findings did suggest that early sedation coverage may stabilize patients post-intubation, potentially contributing towards faster recovery and ventilator weaning. There were some limitations to this study, first being the retrospective design, this then being a single center study. Largely, the study was based on the accuracy of documentation in the EHR. I was largely dependent on medication administration times, and so that could be a limitation. And there was a small sample size as well of the bridge therapy group. The overall conclusion of the study was, while bridge therapy was not associated with a reduction in early rescue bolus use, it was linked to an improved early sedation timing and significantly higher rates of early extubation without increased adverse events. These findings do support the continued evaluation of structured post-intubation sedation strategies in the ED and underscore potential clinical impact amid early protocolized analgesia and sedation. So in conclusion, bridge therapy can offer a safe and effective strategy to smoothing the post-intubation transition and improving ventilator outcomes.
All right. Thank you very much. Does anyone have any questions for Dr. Mitchell? All right. Hearing none. Thank you very much, everyone, for presenting. Thank you very much for attending. We started 5 minutes late, which I'll take as my fault. So we're actually 2 minutes early on time, if you count it like that. So thank you very much for attending. Everyone will be receiving an email from Lecture Panda. Please fill it out, complete your evaluations in order to obtain your CE credit. We'll just again thank you everybody for attending. Have a great night. And if you are attending the FSHP annual meeting, please feel free to sign up for our EM and Critical Care Clinical Forum social so that we can meet in person. Have a good rest of the night.
Thank you. Good job.